And again, it's my pleasure to introduce our speaker today, Professor Keymanthri Moodley, who teaches and conducts research in the Department of Medicine at Stellenbosch University, where she's also the director of the Center for Medical Ethics and Law. It's always a pleasure as a lawyer to see a Center for Medical Ethics and Law within the Department of Medicine, so glad to see that. Professor Moodley has also an adjunct appointment with the Department of Social Medicine at University of North Carolina, Chapel Hill, is a family physician and bioethicist, and we intersect often around our joint work around in Fogarty, with Fogarty NIH training grants, where Professor Moodley herself has had funding from Fogarty for, I believe it's been, what now, about 7, 8 years, and runs a doctoral program now at Stellenbosch in bioethics. So maybe I'll just leave it at that and allow you to say anything else you'd like, Keymanthri, but welcome again and thank you very much.
Good afternoon, good morning, Joe. Good afternoon and to others. Thank you very much for inviting me to participate in this webinar today. And we're really delighted to be part of this initiative. Please let me know if you can all hear me well. Joe, are you, is the
audio great?
Yeah, okay. So as Joe has already said, our center is involved in a number of different NIH-funded projects, and one of these has been the HIV Cure project, which we have worked on in conjunction with the University of North Carolina at Chapel Hill for the past 5 years. And as part of this project, we've conducted different aspects of empirical research. Needless to say, when we first started, we all had to do a large amount of literature research around the concept of HIV cure. And 5 years ago, there was very little published data, especially with respect to low middle income countries. And so today I'm going to share with you some of the research that we've done and some of the community engagement activities that we've been involved in. The talk for today focuses on the psychology of cure, which we think is going to present a very unique challenge to consent processes where HIV cure research is concerned in South Africa. So for those of you who don't know, we have a beautiful country with a very high Gini coefficient, unfortunately. And this means that there is huge disparity in terms of socioeconomic advantage. We have many poor, vulnerable communities. And regrettably, these are the communities that become research participants in various different aspects of health research. So South Africa has a population of approximately 58 million people, and 9% of our GDP is spent on health. However, given the long history of vulnerability in the country, public health services are still compromised, and conducting research can be challenging at the best of times. We also have some communities that have suffered educational disadvantage related to the previous policies of apartheid in South Africa, which I'm sure many of you are familiar with. Now, apart from all of this, many of you will know that South Africa has been a hub in terms of HIV research. And we have an extremely high burden of HIV disease. As you can see, currently the 2017 figures reflect 7.1 million people who are HIV positive, 270,000 new infections over this period with 126,000 deaths. And despite all of this, we have only 56% of our HIV positive population currently on antiretroviral treatment. And this is the situation after almost 3 decades of preventative and therapeutic interventions in the context of HIV/AIDS. Now, given that we still have such a high burden of disease, it's quite clear that both prevention methods and treatment options are not entirely bringing this epidemic under control in our environment. And so from a scientific perspective, it makes complete sense that we start exploring so-called cure options in the field of HIV/AIDS. Now, many of you will be aware that scientifically this is a very complex subject to discuss, especially because the methods proposed are sophisticated and challenging. To establish a cure is definitely not going to be easy scientifically. So as you can see on the slide, we have a number of different strategies that are under investigation and that have been proposed. Very early treatment, I think, is one that we may be most familiar with, and examples would include, the Mississippi baby, and I'll speak a little bit more about that later. And of course, there's also a South African child who has been exposed to extremely early treatment with antiretrovirals. And then, of course, very interesting other approaches, like, for example, the shock and kill approach. As you know, the total HIV burden in the body is quite high. Not only is there circulating virus, but with treatment, it is possible to eliminate circulating virus. The challenge we face is that a large proportion of the virus actually resides in so-called reservoirs in the body, so in the lymph nodes, in the gut, in the brain, and those cells infected with HIV are difficult to access. So strategies have been developed around the possibility of finding ways to entice the HIV out of those so-called latent cells and then killing them or exposing them to the immune system, and that is referred to as the shock and kill approach. There's also a lock and block approach, which focuses on finding ways to lock the HIV into those cells in the various reservoirs so that they don't escape it at all. So that's almost the opposite of the shock and kill approach. Then more recently, I'm sure you've heard a lot about gene editing, especially with the CRISPR baby in China, and attempts to use gene editing at a very early stage to prevent people from developing HIV. And more recently, there has been a considerable amount of research around the use of broadly neutralizing antibodies, as well as therapeutic vaccines. And so we're mostly familiar with preventative vaccines in a whole host of conditions, but as a cure strategy, we would be looking more specifically at a therapeutic vaccine. What is also becoming more and more apparent is that using one of these approaches may not be sufficient, and it may be the case that we would have to use a combination of these different approaches to effect a scientific cure. Now, establishing all of this is challenging, and it's even more challenging when we start looking at the language around HIV cure. So there have been publications by Rennie et al. Entitled The Ethics of Talking About HIV Cure, because that in itself is an important point of departure in this discussion. And when we refer to cure, what exactly do we mean? Are we talking about a remission? And when we speak about remission, it means that the possibility exists that the infection might come back. And so what we have seen so far have been examples of transient remission. Again, the typical example is the Mississippi baby, who was initially thought to be cured, initially tested negative, and then several months later, unfortunately, tested positive again. And so clearly a sustained remission is what we would be, hoping for. And then there's the concept of eradication. And when we start to talk about eradication, we are looking at a more persistent, lasting type of cure with complete eradication of the virus. Here too, we talk about functional cures and sterilizing cures, and these terms themselves are controversial, and there are a number of interesting publications on the use of such terminology. Now, I think in the South African context, the language around cure is particularly challenging because we've had a very long history of fake or illegitimate cures in the country, and people have had all kinds of information released in the media or otherwise about possible cures, and a wide range of people have been instrumental in offering these so-called cures. They range from politicians to medical doctors to healthcare workers, and it has sometimes even religious leaders. And so this has created a large amount of confusion, and so introducing a scientific cure in the context of the history of illegitimate cures is yet another challenge that will be faced by scientists and ethicists alike. And so in order to establish perspectives on HIV cure research in South Africa, we conducted some research and tried to explore a range of multiple diverse stakeholder groups to establish what their initial perspectives were on cure, and of course how this information could impact on consent processes and research ethics committee reviews in the future would be an important consideration. So as part of our research, we started off interviewing a range of patients, healthcare workers, and community advisory board members in an HIV clinic in Cape Town. And having established, perspectives at that level, we then progressed to interview HIV experts in our country, and then proceeded to do a more in-depth study involving about 30 stakeholders and 15 participants who were involved in focus group discussions. And as a result of all this research, we have a number of publications out. So today, what I'm going to share with you is results from all of these engagements with the different stakeholder groups. So you can see in terms of stakeholders that it involved researchers, clinicians, activists, psychologists, policymakers, patients, medical students, community members, as well as pharmaceutical companies in 3 different cities in South Africa. Obviously, the research was conducted with consent, and there were 58 in-depth interviews and the 2 focus group discussions, and we used a contextualized thematic approach. Now, what was very interesting is that from our initial studies, there was considerable discussion around what it would mean to actually have a cure, and people seem in this country, well, to some extent, to have a misunderstanding around cure in terms of relating it to treatment. So there, if you look at the actual words of one of the participants who were interviewed, the understanding is that if you take your treatment and if you adhere to your treatment, you can be cured. So there is already a belief that if you take your treatment properly, you will be cured. And so at some level, while we understand how this understanding comes about, we know that scientifically, with treatment alone, HIV is still going to be located in reservoirs. And so technically that would not be regarded as a biological cure. There was also concern about what we would mean when we would when we were engaging people about a cure, because a cure is regarded as a quick fix, you know, something that is just a once-off interaction that people, you know, think you can be cured, and then after that you do not have to take medication for the rest of your life. So there's also that perspective around cure being a quick fix. And yet we know that there will have to be long-term follow-up and long-term engagement to ensure that whatever remission or cure occurs is actually a sustained cure. And so clearly, you know, very interesting perspectives around cure. And then of course the concept of remission. So I think when remission is discussed, we often think about cancer, and people with cancers are familiar with the term remission, because doctors would tell their patients that you may go into remission, but the disease might come back again in the future. And so that concept is clear in the field of cancer research. But when we move on to looking at HIV cure, there might be a misconception when we speak about remission, and we need to be careful about that. So a very interesting perspective that we gained from our patients interviewed early on was that they saw the risks involved in HIV cure research as being more than the type of risks we anticipate in other types of medical research. So at a biological level, a big concern with cure research revolves around treatment interruption. And we know that some trials will be designed in a manner that would require a period of treatment interruption. In other words, patients would have to stop taking their antiretrovirals in order for us to see if the new intervention is actually going to work or not. And this is quite a difficult instruction, you know, to give to a patient, because we have been talking about the importance of regular treatment, compliance, not stopping antiretrovirals, and now suddenly there might be a new research approach that would require people to stop their antiretrovirals for a period of time or indefinitely. And this can be a confusing message. So participants saw treatment interruption as an important biological risk, with a number of concerns linked to this. Of course, participants raised the importance of the psychological adverse events or risks that might exist. So because the word cure would be used in a study, it has the potential to create an expectation of cure, and if this does not happen in the course of research, then participants indicated that it would be devastating to many participants. Of course, we know that in medical care and in research, we cannot offer a guarantee of a cure most of the time. So this is another important consideration in how we word consent documents and how information around cure studies is communicated to potential participants. And of course, they also raised a number of social issues around trial participation, linked to the fact that some participants would not inform their family members, or that there would be concerns over some family members having access to cure trials while others could not, especially where more than one member of the family were infected in a household. And so to focus a little bit more on the risk-benefit ratio around treatment interruption, I think some participants said that there might be patients who would say, I'm living happily on my ARVs. Why rock the boat? A very important consideration from the patient's perspective, especially people who are very well controlled, who have been compliant with their antiretroviral treatment, and who are living a better quality of life and experiencing better health outcomes because they have been on the antiretrovirals for so long. It was, however, felt by others that for those who are not adherent on treatment, that risk would be smaller. So if people have been non-compliant, have not been taking their treatment, and they were approached about a study where treatment interruption was a component, then perhaps they would not see it as a big a risk as others would. And there is a serious concern in the country around adherence, and one HIV policymaker indicated that of 1,000 adolescents that they were studying in the Eastern Cape, only a third were adherent. And so this is a current challenge in general with respect to adhering to antiretroviral treatment, which also makes an important argument for developing a cure, because long-term antiretroviral treatment is quite difficult to take, and it is not surprising when people stop taking their medication over a period of time. From a psychological perspective, we know that there is always a feeling of desperation amongst people who are infected with HIV. And if one is extremely desperate for a cure, then some people might be willing to try anything, even if it's not in their best interest. Again, a perspective from one of the research participants. And so discussions moved on to consent processes, and how informed would these processes be, given that we are dealing with extremely complex science? So apart from just explaining HIV and the immune system, etc., like we normally do, the discussions would have to include things around reservoirs, latent infection, and then very complex strategies like gene editing, etc. And so we already know that there is a large body of literature around understanding of consent information and recollection of what people are told. So another sentiment expressed in the study. And of course, the clinical trials would be conducted for a very long period of time. And during this time, new information might become available, new drugs may be developed, new cure options might be developed. And, this information would have to be communicated. Other aspects of the science may change. And so some of the participants mentioned the prospect of reconsent. So in long-term studies, it's not unusual for there sometimes to be a requirement for reconsent because people forget information over time. And so an important consideration from a researcher perspective, as well as from the Research Ethics Committee, is to consider, the need for possible reconsent on an annual basis in the context of long-term studies. And then, of course, other participants indicated that we need to start thinking more clearly about engaging in dialogue beyond the traditional consent process. To the extent that some felt that an extensive psychological evaluation might be necessary to see if participants were in a stable position to understand their involvement in the study and to cope with the consequences in the event that the cure did not work. And more we were hearing from our research participants that it was a matter of going beyond consent to thinking about a counseling process. Of course, research ethics committees would need to be trained and to understand and review the studies, because a lot of new science is involved here. And of course, there would be a requirement for regulatory guidance and policy to be developed in this area, both at the ethics committee level as well as at the level of regulatory bodies. And so clearly what we could conclude from our study is that if there is proposed HIV cure research, in South Africa, early community engagement would be non-negotiable. And while we have these discussions around cure, it would be very important to maintain messages around prevention and treatment so that we do not end up in a situation where the dialogue around cure eclipses discussions around both prevention and treatment. And of course, I think what was really an important finding in the study is the important psychological implications and how these would impact on how we would view consent, both from a research ethics perspective and from a regulatory perspective. And given, you know, the engagements that we had with study participants, given the need for community engagement, we then proceeded as part of our project to also develop a number of engagement tools. So we've made a video on HIV/AIDS looking at prevention, treatment, and cure. And this is available on YouTube. We've also developed a series of educational pamphlets that cover all three components, so treatment, prevention, and cure, ensuring that messaging around cure, you know, did not displace messaging around treatment and prevention. Because education at schools is important, where HIV is concerned in South Africa, we developed an activity book. In fact, it was developed by 2 medical students, and this is a sort of an interesting, fun type of book that encourages young people to think about HIV, to understand the science better, and also to engage with the concept of cure. In our public health facilities, patients wait for many hours to see healthcare providers on a daily basis. And so we thought we would develop an interactive online module that patients in the waiting room could access to help them with their boredom and to ensure that they were up to date on new developments in HIV prevention, treatment, and cure. So we developed a series of educational modules that are available to patients in the waiting room of the particular HIV clinic where we work. We have 2 kiosks with 2 computers, 2 touchscreen computers and headphones, so patients can spend 20 minutes going through the modules and answering some questions and hopefully engaging more with the subject. So this was a part of our project, but the modules remain in the clinic, and even after our research, they are being used by patients in the waiting room. It's also a very useful tool so that for future cure studies, consent information can be conveyed using this tool as well. And so at the end of the project, what became very clear to us was that in any research involving complex science, community engagement is really critical. What was important for us in the development of all of these materials was that we engaged with community members, community advisory board members, healthcare providers, in order to find the language that would be most suitable and to find ways of conveying the information that would be well received by lay patients and research participants. And of course, testing these modalities was also important. So we conducted before and after studies using the video. We did a before and after study using the interactive modules, and these are published as well. And what we did find was that there was an improvement significant improvement in understanding after being exposed to these educational modalities. And so for today, I think I need to acknowledge my collaborators and co-workers, research assistants, administrative assistants, the patients and the participants that were involved in these studies, and to acknowledge the NIH for funding the study. And I hope that this has been interesting and useful to you, and I'm now happy to answer any questions.
Thank you very much, Keymanthri. That was very enlightening and helpful. I think I will just take a moment and invite those who are participating to either share questions or comments in using the chat. If you hover over the bottom of the screen, you can find the chat button. Or if you prefer, you're welcome to unmute yourself and share a comment or question that way. If you do, it would be great to maybe just introduce yourself first, and then we can go from there. I will give a moment for anyone to raise questions or comments, and while doing that, maybe just ask my own. I'll take the moderator's prerogative, and maybe just see if in your interviews and focus groups discussions, if you've found anything that sounded like what some colleagues of mine here, Jeremy Sugarman and others, have sort of been exploring this notion of preventive misconception. It sounded like some of your results were hinting at that, but Professor Sugarman's work, I think, and others, has built on this notion of therapeutic misconception in research and clinical trials, to think and sort of explore empirically whether there might be a notion of preventive misconception in HIV prevention research. And I guess I'm wondering, in the context of cure research, whether there's something similar or similar concern that people who participate, maybe if there are some short-term positive effects, might believe that it's not possible to get HIV again, or may believe there's some, depending on the nature of the intervention, of course. Anyway, just seeing if that resonated at all.
Yeah, Joe, I think curative misconception is going to be a challenge in HIV cure research, as much as therapeutic misconception is in other types of treatment-related research. And the expectation to be cured, maybe even the desperate hope to be cured, would be a significant factor, which is why the psychological aspects of such a study would be important. Because I think we would have to spend considerably more time than usual to ensure that there is no, that there is no guarantee of a cure, even though the study might be called a cure study. So that in itself is a challenge, that the study is called a cure study in the first place, because it feeds into that possibility of developing a curative misconception. So perhaps we need to be more careful about how we name our studies and the language that we use to ensure that we do not create the curative misconception.
So I see there are a few questions coming in. Maybe I see one question indicating that love the interactive tools, and seeing if those are available anywhere to share. So let you maybe address that one quickly.
Yeah, so the video, as I mentioned, is on YouTube, and it's very easy to access. The pamphlets that we have are electronic, so if you require pamphlets, we have them on our website, and the website is www.sun.ac.za/CMEL. Diana would be happy to send that out later, I think. Sure. And of course, to contact us directly if you require anything in electronic format. The modules are not shareable at the moment. They they are on the two computers and the kiosks, and I think there are a number of settings involved there that we that are not that easy to share. So we will possibly, you know, explore that going forward. But yes, everything else, the activity book is also available.
Excellent, thanks. Maybe I'll let Karine, I see your question here. I don't know if you'd like to unmute and maybe ask yourself the question.
Thank you. So my question was, well, first of all, thank you for this excellent webinar. What would be your recommendations for introducing analytical treatment interruptions in the South African context?
You can see that many of our research participants were concerned. Our video explains this a little bit because it was very important to have this discussion as part of the video. There is definitely going to be concern when you tell a South African HIV infected person to stop their treatment. What is important is to prepare participants adequately for that part of the trial. Important that there is adequate discussion around it during the consent process. Ensure that there is a test of understanding associated with the consent process so that it is clear, but also to reassure participants that although their treatment is being interrupted, they are also being monitored extremely closely at the same time to make sure that no harm comes to them because of the interruption. So I think those are some of the approaches that would be necessary to use.
Thanks. And Victor, I don't know if your audio is active, but you're welcome to raise your question as well if you'd like. Or I can raise, maybe I'll raise it for you if you're having issues. So Victor asks, it will be difficult ethically to carry out HIV cure research without current treatment. So stopping treatment, for example. Researchers may have to find ways of doing the cure research while on ARVs, unless very sure that they will be cured with HIV cure intervention. So maybe helpful to talk through what are the implications of that, Keymanthri.
Yeah, so you know, this is it's similar to the discussions we have around the use of placebo. And so one approach is to consider, you know, adding on a new intervention to current treatment. But that could be problematic where HIV is concerned, because one wants to see, you know, the impact of a new intervention, especially when we talk about cure. However, it is possible. What I'm starting to see in the literature is more and more discussions around the use of combination therapy. So, you know, using maybe a different antiretroviral in conjunction with a new intervention. Also using, you know, other types of treatments. So I've seen reports recently about using the drug metformin, which is a drug used for diabetic patients, possibly where we would use the metformin, or the glucophage is the other name, but use that drug in combination with antiretroviral treatment to see whether a cure can be established. So there are those options, but there are certainly some trial designs that would require treatment interruption.
Thanks. JFB, is that you, John? Would you like to raise a question?
Much for this wonderful presentation.
I think you're very quiet.
Oh, maybe my volume is.
Here, I think we can hear you sufficiently, though.
I think my volume was a bit low. Now, thank you very much for the very good presentation. My concern is about a possible selection of study participants that will not raise ethical issues, because in principle, it would be morally controversial to tell those people already adhering to ARVs to stop ARVs before, without knowing that the product being tested will be effective. But I was wondering, you have stated that the rate of adherence among the youth in some part of Cape is about a third. Have you people thought of a possibility of instead using people who are non-adherents to ARV treatment as study participants? Because in that case, it would mean that the participants are not exposed to any more risk than they would stand without the study.
That's an interesting suggestion, and it was, as I presented earlier, one of the suggestions by some of the people that we interviewed, that maybe the non-adherent population would be a more suitable population. But then, of course, that introduces a bias into the study already, and it is. I've also seen the literature discuss issues around the use of terminal people in such types of research, bringing with it a number of ethical concerns as well. So yes, it is clear that there is anxiety around treatment interruption, and that people are thinking of, finding less risky ways of conducting the research by choosing the study population more carefully.
Thank you. I see there are a number of questions coming in, so it's great. So Mike, is it Michael? If you feel free to share if you'd like, or I can do it on your behalf. Well, I'll just read it out for everyone. So how would approaching the consent process change if we were to approach it like counseling? So thinking maybe a bit about, the implications of a more, dynamic consent.
Yeah, so counseling, I think, how would it differ? It would be definitely a longer process, and coupled with a good community engagement plan, which I think is important in most types of research. We could, engage with potential participants at an earlier stage of the research, and spend more time on establishing, what is understood, what is not understood, what the most appropriate methods or tools would be to improve understanding, and to involve some level of psychological support. So as things stand, we generally do not involve a psychologist in the research process or in the research team, unless, of course, there is some type of social science research that requires debriefing after an interview, for example. So my understanding in terms of research ethics is that we usually ask for debriefing where we feel a specific type of social science research might upset participants to such an extent that they would require debriefing. But that usually happens after the research. Here, I think what is more important is looking proactively at assessing people's psychological readiness to expose themselves to a different type of study, to a higher level of risk perhaps, and to assess, their complete understanding to prevent curative misconception, and also to prepare them for the eventuality of the intervention not working. In other words, in it not being curative at all. And of course, the need to return to just simple antiretroviral treatment at the end of the study. So this type of research can create hope, and those are the issues that need to be managed in advance of the study. It would mean much bigger study budgets, I can assure you, because we are, involving different service providers as part of the research team. In many countries, psychology services are not easily accessible, especially in the public health sector. And so we are sort of making our studies will become more complex in terms of the study team. But it is also possible to have more, specifically trained counselors who are not exactly psychologists, but have been very well trained in terms of assisting participants to prepare and to understand this type of study.
Thanks. I see Mary Kasule, I believe, in Botswana is indicating that they're planning a similar study. So I think looks like there might be a good opportunity for the two of you to chat. So maybe we'll do that one offline. Setlomo, do you want to share your question?
I don't know whether I am clear.
Yeah.
Thank you, Professor Moodley, for the wonderful talk. I come from Botswana, and when you talk of South Africa, you are talking at least about me in particular. And when you brought in the issue of misconception around the issue of Q, maybe that maybe mostly come from religious leaders. And we know that in Southern Africa, at least where we come from, people go to churches with the hope that they get healed, get touched, that we have this misconception that is going on. But my biggest issue right now is what plans, because you see that these religious leaders are very, very influential on the mass of communities. What plans are there in place to engage directly with them so that we maybe this, because this issue can be really, really very impact on the community that are misled maybe by the same religious leaders. Thank you very much.
Thank you for that question. It's I think one of the most difficult challenges we face in not only in South Africa, but many other African countries as well. And it's not only religious leaders, but sometimes even politicians themselves who market so-called HIV cures. Clearly, this matter has to be addressed. I know we have a very long history in South Africa. We've been able to manage some of the, the misconceptions that have been created as a result of so-called charlatans, so-called religious leaders and politicians offering cures. But I think it remains a constant possibility that this will continue. So, regulating against it is important, and having, quite severe sanctions for those who indulge in this type of conduct is critical. But we also have to consider that in many communities, there's a strong traditional medicine component to healthcare. And many communities will visit a traditional practitioner in addition to a Western healthcare provider. And under these circumstances, it's sometimes not as easy to establish legitimacy of cure. So there may be other types of interventions that are used in terms of herbal medication that we are not familiar with. And if they are marketed as cures, then we have very little control over that. So in South Africa, traditional practitioners are, part of the regulatory framework in terms of there being a specific body to regulate traditional health practice. And I still think it's in its infancy. So there are sort of alternate systems of healing that exist in all our countries. There is the Western healthcare system, and then there are the other parties who indulge in these illegitimate cures on the basis of commercial gain for themselves. And so to ensure that there is a good regulatory structure in place is critical, but very importantly is to engage with communities at a very early stage and to educate at various levels. So, making people aware the possibility of other cures that are being marketed is important, and differentiating between what is being offered in the Western research world as opposed to what is being offered outside of that context is also important.
Thank you. Mary Dong, would you like to raise your question? Looks like it. Quite an interesting question there about ethical responsibilities of sexual partners of research participants who engage in treatment interruption. So sort of third-party responsibilities in that context, whether that's something that's come up in your work or other discussions.
Yes, no, most definitely. I think partners are so important in HIV research, and I have written about this in the context of microbicide research. So what we find is that many studies enroll participants alone, and there is less involvement of partners. And this is important because on many levels. So I think at a very basic level, we've had women involved in studies, for example, the Depiverine ring studies, where they were exposed to domestic violence because they did not discuss their participation in a trial with their partners. So that's the first thing, is that it's important to encourage participants to discuss their trial participation with their partners. In some cases, this is possible. In other cases, women decide not to do this for a host of reasons. And it's difficult to enforce under those situations. So usually the language is encourage discussion with the partner, in terms of consent documents, etc. Involving participants, partners is important in some settings. And I think in the context of treatment interruption, this would be really important. It may be the case, we know there is often, in addition to whatever HIV intervention there is, there's always the package of prevention that goes with the study. So provision of condoms, availability of PrEP. So PrEP has recently become a very important tool in the prevention sort of toolbox. And so, consideration for the need to keep partners on PrEP and to encourage a range of other prevention measures will be important and needs to be built into the trial design at a broader level.
Thanks. Actually, there are a few more questions. Maybe I'll just jump in and ask a question that relates, I think, to some of the individuals on the webinar who either administer or serve on ethics committees. You had mentioned in the middle of your talk that perhaps more training or resources directed at ethics committees would be of use going forward. And it sounds like most, if I'm not mistaken, most of the interventions or tools that you developed so far have focused on communities or research participants or researchers. Did you have thoughts on maybe what would be helpful to ethics committees that are reviewing HIV cure research, if there are any other sort of toolkits or guidelines or things like that?
Yes. So our project is now over in terms of the funding, and most of it was around, the project itself focused on engaging with communities around cure, looking at both intended and unintended consequences of cure research. I think another project would be important around looking at, engaging with other stakeholders in the process. So we also have a number of different research ethics events in South Africa, and we've included, discussions around HIV cure because at many of these events, our audience comprises both researchers and research ethics committee members. So we've used those events as opportunities to discuss HIV cure, but I think we would need more focused training. So we are presently developing an online training course in research ethics, and HIV is an important component of that. It will take us several months to finish all of this development. We've only just started with the first modules, but developing educational opportunities for research ethics committees specifically focused on HIV cure research is important, as much as it is important given updates in treatment and prevention. So, you know, discussion around PrEP, discussion around long-acting PrEP, such as cabotegravir. These are all potential training opportunities for research ethics committee members who are currently reviewing studies and who will review cure research in the future.
Great, so I see we only have maybe 1 or 2 minutes left, and we have a couple of 3 questions in the chat box here. So maybe I'll just throw them all at you quickly and see if you have any thoughts about any one. The first relates to if there's any concern around failure, in cases of failure of cure in the context of research, if that somehow had down the line effect on people's ability to respond to ARVs, other types of treatments, and maybe some harm, potential harm there. Mm-hmm. The second relates to, from Robert Steele, about a project led by Gil Henderson and colleagues founding HIV Cure research in Thailand, having sort of effect of participants perhaps wanting to partake in research that involved interruption of treatment, as it provided potentially some kind of break from medication under supervision, and that being a sort of positive thing in some cases, and whether that came up. And the lastly is from a colleague writing about ACTG cabs in South Africa, and that they're well informed, are utilizing you know, the experience of cab members and, in the context of this work. So just throw those out there at you and see if anything in the last 10 seconds or so.
Okay, yeah, oh my word, 10 seconds and such important questions. So
sorry about that.
Yeah, no, certainly failure of cure holds the concern about potential harm. As it is, you know, we know so little about many of these new interventions that are being used for cure. Gene editing, for example, we know if that is to be used, then the potential for harms exists in terms of off-target effects. So I think before we have these discussions with potential participants, it's important that we are more familiar with the risks, and that they are properly discussed, and that provision is made for the potential for harm for those who are willing to take the risk, you know, that there is some kind of fallback plan, or, you know, what option would there be afterwards, new generation drugs perhaps. So a great deal of research that has to occur in parallel, both in terms of the intervention and also in terms of options for if the cure doesn't work. I think the idea of looking at supervised treatment interruption as a break could be a reality for those who have been on ARVs for a very, very long time. And yes, that in that case, it would be viewed as a positive aspect. And of course, cabs are invaluable in most settings, assisting with conveying research information to participants and in educating communities. But I think sometimes it's not enough to simply have a cab. I think the community engagement process needs to be broader than the cab.
All right, well, thank you very much, Keymanthri, on behalf of everyone, for your lovely talk, and thanks to everyone for joining today. Hope we found it to be useful and enlightening. I'm sure it was. So stay tuned. We will be in communication about future webinars in this series. Thanks very much.
Thank you, Joe. Thanks for all the questions. It's been a really lovely session.
Thanks.